When you have heart failure, what's going on in the alveoli?
Congested with fluids.
Okay, so the alveoli has fluid in it. The interstitial space has fluid in it, which means it's not being moved anywhere, which also means that it's housed in the lungs. And depending on if it's right-sided or left-sided heart failure, some of that's also moving into extremities and your organs. So why would we want to know about the urinary output? What's going to be the key treatment for that? If we have fluid in the lungs and we also have fluid.
Diuretics.
Okay, so what are the two things you should be monitoring with diuretics?
Yeah, the urine output.
Besides urine output?
Your potassium.
Okay, we're going to monitor potassium, urinary output, and what else?
And lungs.
The lung sounds. So if we give them Lasix, then we want to make sure that our lung sounds are no longer congested, right? If we give them Lasix, we want to make sure that those dependent extremities, like your legs, the lower extremity, that those are no longer swollen. Correct?
Yes, ma'am.
Okay. So you have to look at both pieces. And you want to ask the patient, have they been compliant with their medications? There's another lab value that you want to consider, which is the BMP, right?
Right.
What number should that BMP be to be considered normal?
Less than 100.
Less than 100.
Yeah.
So if you have a BMP that's 400 or 500, 1,000, what should that be telling you?
He has severe heart failure.
The heart failure is well developed.
Yeah.
So with that being said, you have to look at all of those pieces. You can't say that we're done with the heart failure until we're looking at all of those components. That's part of your management. And that's why, I covered the heart failure part. So that way you would know, what to do. There's one other thing that's also a part of heart failure. What is that? This is not necessarily a lab test, but it's a diagnostic study. Oh, hold on. Ejection fraction, that is correct. Thank you, Teresa. So ejection fraction is another value that you would need to look at. What would that number have to be in order for the patient to be considered to be in heart failure?
More than, less than 50.
Less than 50, so in the 40s. Thank you, Melissa. So if the normal ejection fraction is 50 to 70, somewhere in there, that's normal. So if it's less than that, so less than 40, then and that's what the literature says, if it's less than 40, then they have decreased tissue perfusion. So if I have left-sided heart failure, what is that usually related to? What conditions bring that on? What brings on heart failure in the first place?
High blood pressure.
High blood pressure and previous heart disease. So that'll bring on left heart failure. Pulmonary disease is what brings on right heart failure, if it's happening by itself. Does that make sense?
Would that be something like maybe COPD or?
Correct, because remember, COPD, you can end up with cor pulmonale.
Okay.
So usually when you have acute heart failure, that's going to be right after somebody has a heart attack, or, you know, early, it'll be their first onset of someone who has not managed their hypertension. That's when you're going to see acute heart failure. And there's several other conditions where heart failure can come into place. There's been folks that have delivered a baby and gone into heart failure directly after. So does that make sense, Rasha?
Yes, ma'am. And please, I have another question regarding also to heart failure. Why we check TSH and CBC to assess the left heart failure?
Why do we check what?
TSH and CBC.
We check those because for right-sided heart failure, or not for right-sided heart failure,
Left side.
if you have hyperthyroidism,
Yes.
or if you have an infection or anemia, you're going to end up with high cardiac output, which could be related to, they can end up with heart failure. So if they have high cardiac output, they probably have either hypothyroidism, an infectious process, anemia, or they're pregnant. If they have low cardiac output, they probably have coronary artery disease, high blood pressure, or cardiomyopathy. That's why we're looking at those.
Okay. Heart disease, cardiomyopathy, and what? What else?
Hypertension. So coronary artery disease, so CAD, hypertension, and cardiomyopathy.
Okay.
That will give you low cardiac output related to heart failure. High cardiac output related to heart failure is because they have hyperthyroidism, an infection, anemia, or pregnancy. Does that make sense?
Okay. So, high cardiac output related to hyperthyroidism, infection, anemia, and pregnancy.
Right. If they have, you can have two types of cardiac output in heart failure. You can have either a high cardiac output or a low one.
Okay.
If you have a high cardiac output, then that means that your heart failure is due to anemia, pregnancy, hyperthyroidism, or an infection.
Okay. And the low cardiac output is for heart disease, myopathy, and hypertension, right?
For low cardiac output, that'd be coronary artery disease, high blood pressure, and cardiomyopathy.
Okay. Thank you.
Mm-hmm. Other things you would see on assessment besides the, rails when you auscultate and, dependent edema, you would also be looking for a gallop with the heart tones, JBD, shortness of breath, right?
Yes.
So you have to consider all those other pieces as well.
Okay.
So how the BMP works which are, these are biomarkers that are released by the ventricles when there's excessive pressure related to heart failure. So how it usually works is that if they don't have heart failure, their BNP, that'll be, beta Nancy Paul, would be less than 100. Heart failure is present between 100 and 300. Greater than 300, they have mild heart failure. Greater than 600, they have moderate heart failure. Greater than 900, what would that be?
Severe heart failure.
That'd be severe. So you have to know more than just greater than 100, because the severity of the heart failure is just as significant. Now, the ejection fraction, the only way you can get that is on an echocardiogram. So that's a diagnostic test that would have to be done.
Did you say echo or?
Yes, ECHO.
Echocardiogram.
Correct.
Got it.
Not electro, echo, ECHO. When should you be concerned about a patient's weight gain with heart failure?
Congestive?
How much weight? How much weight? If it's more than 5 pounds within a week, correct. So 5 pounds or more, if they gain 5 pounds or more in a week, that's significant. That needs to be reported. If they gain 2 to 3 pounds in a day, is that significant?
Yes.
Absolutely, because if 5 pounds in a week is significant, that's a pound a day for a week, not even a whole week, just for 5 days. So if they're gaining 2 to 3 pounds in a day, they're filling up quick. When would be, if your patient's taking Lasix, when would be the best time for them to take the Lasix?
In the morning.
Absolutely. We don't want them peeing in the middle of the night. They may not make it to the bathroom. So when we're doing teaching, then we need to make sure that we let them know that. And usually you will see that weight gain in more of the left side of heart failure than right, with the 2 to 3 pounds in a day, 5 pounds in a week. On the right side, it's a lot of swelling. So, the neck veins are engorged, their legs are edematous. They still have that weight gain issue with the 2 to 3 pounds in a day, 5 pounds in a week. Liver's swollen, hands are swollen, their abdominal girth because they have the ascites, right?
Yes.
So, that's the side that usually has the AFib. On the left side, they're doing more drowning than swelling. Does that make sense? Because their lungs are full of fluid, the fluids in the interstitial spaces. Their heart rate's going to go up because it's trying to pump that blood through and get out to the organs. They're coughing, and then we're looking to see if this moves to pulmonary edema. And how would we know that we've moved from heart failure to pulmonary edema?
Shortness of breath.
They're all going to be short of breath.
Maybe they're O2.
Nope. There's usually a sign that they display that lets us know they've moved from heart failure to pulmonary edema.
They cough, pink sputum?
It's pink frothy sputum. Great. So that's how you know they're moving into the next piece.
So moving from what stage to what stage?
When a patient's moving from left heart failure to pulmonary edema, what would you see?
Okay, got it.
And that would be your pink, frothy, or blood-tinged sputum is what you'll see. Is that more or less significant?
More significant.
That's gonna
Estoy en mi casa.
Okay.
So he getting worse now if he move from left heart failure to pulmonary edema.
To pulmonary edema.
So the patient getting worse.
Exactly.
Okay.
All right, so we kind of talked a little bit about management, right? We talked about Lasix. From a non-pharmacological standpoint, you know, diet, what kind of dietary restrictions could we talk about?
DASH diet.
DASH diet, okay. How about soda?
No soda.
No soda. So restricting fluids, you know, restricting their water, restricting their soda intake. If they have an infection, then that illness is going to stress the heart out even more. Things we also need to look at is our renal failure that can develop if they're not compliant with their medications. They can end up with AFib. So our goal is to look for the presence of the condition and when it's getting worse. That's kind of our role. What medications could they receive?
Diuretics, ACE inhibitors.
So
Beta
ACE inhibitors, ARBs, ARBs,
ACE
vasodilators,
inhibitors or RBs, or they can take together.
ARBs, apple, Rita, basketball.
So he can take ACE inhibitor with ARBs or
That's
this
not
or
what I
this.
said. I'm just basically listing classes of medications that they can take.
Okay.
Things to work on the blood pressure would be ACE inhibitors, the ARBs, or vasodilators. Things to work on the heart rate would be DIG to decrease the heart rate. And then what assessment should we do if we're giving them DIG? What's our nursing assessment? If we're going to give them, we're going to check the heart rate. Thanks, Orfanelli. So we're going to check those. Then we give them a diuretic, and then we have potassium sparing and potassium non-sparing. What complications do we have with both of those?
Heart rate.
If they receive too much of it. Or what can potentially happen, not necessarily if they receive too much of it, but if they receive it and the patient diureses a lot, we're going to end up, thank you, Melissa, with potassium imbalances. So either we're going to have hyperkalemia or we're going to have hypokalemia. So if they're on potassium non-sparing, we're going to have hypokalemia. If we're on potassium sparing, then we will have hyperkalemia. And you can also see potassium wasting with DIG. So you have to watch the potassium there. Your ACE inhibitors and your ARBs are going to increase your potassium. What position should you place your patient in bed? High Fowler's, correct, Teresa. It should be high Fowler's position to help facilitate their ability to breathe. What's the max number of liters of fluid per day they should get or they should take in?
2.
2 liters. So does that answer you all's questions about heart failure?
I have something confusing me. The preload and the afterload, and when it is decreased and when it is increased.
Here's the way to look at preload and afterload. Preload is the blood returning back to the heart. Afterload is the blood exiting the heart.
Okay.
Does that make sense?
Yes, ma'am.
Okay. All right, so who can tell me the signs and symptoms of DIG? Toxicity.
Increased heart rate.
Okay, what else? Actually, it would be it can be increased or it can be decreased, either one. Because they can have supraventricular tachycardia or they can have sinus bradycardia. What else?
I'm sorry, Miss Hudson, did you say bradycardia?
They can have sinus bradycardia or supraventricular tachycardia or atrial tachycardia, so their heart rate can go either or. And we're talking about DIG toxicity. But before we even get to that part, there's other signs and symptoms before that.
Severe headache.
Headache, halo vision, thanks, Teresa. Yellow vision, yellow-green halos, headache, nausea, vomiting, belly pain. On their ECG, this is usually how they diagnose DIG toxicity, is that they'll have a scooped ST segment on the ECG. And basically, you can kind of put a little pill in it. That's how they diagnose DIG toxicity outside of looking at their blood value. So if they did draw a DIG level, it would be greater than 2. DIG has a narrow therapeutic window, very narrow. What's the first line treatment for heart failure? Which medication are they going to give them besides Lasix? Because that's usually further down the line, but what's usually the first one they give? So of those medicines that I talked about before, which would they give first? Lisinopril, thank you, Melissa. They're going to give them an ACE inhibitor, thanks, or Orfanelli. I didn't see the type. So my bad on that one. So other things we need to worry about with ACE inhibitors, you know, whether potassium levels, sodium levels, those are things we need to also look at, those imbalances. Other things we can tell our patients to do to minimize them developing heart failure is smoking cessation and decrease alcohol consumption, because that causes vasoconstriction. You know, when you smoke, the nicotine vasoconstricts the vessels. So any other questions about heart failure? Because if not, we can move on to the next topic. All right, what can you tell me about PVD, peripheral vascular disease? This will be reviewed from previously early in the semester. Lower extremity edema. Okay. Is that with, let me do a clarification. What encompasses peripheral vascular disease? There's two conditions in peripheral vascular disease. What are they? Not necessarily DVT. You could develop a DVT. So the two conditions is peripheral arterial disease and peripheral venous disease. So you can have it from the venous side or from the arterial side. Does that make sense? So Melissa, what you listed as the DVT, is that arterial or venous? She says arterial. Do you all agree? Okay, so Orfanelli says no. She goes, oops. Okay, peripheral venous is where your DVTs come from. They're more venous in nature when we're talking about DVTs. We can have, a clot in the pulmonary artery. That can happen. But that's usually because it started in the vein, down in the leg, and traveled to the lung or the heart or the brain, right? So Orfanelli had up there atherosclerosis. That's usually how the venous part starts, or the vascular part can start, where they have plaques that's made up of salt and cholesterol and calcium and all of that. And so over time, that's going to block the artery. And then we have arterial sclerosis, which is going to make it more hard. So it doesn't, it limits its ability to dilate and to constrict. So usually it's caused by some type of blockage related into a vessel somewhere, right? So how do you know if somebody has a DVT versus an arterial clot? What would be the difference, or how would they present? A DVT is warm and swollen. Exactly. What about a clot? How would you know if you have a clot? It's cold and pale. So if you have a clot in the leg, if it's a venous, if it's in the vein, so if it's in the venous system, then the extremity will get bigger, but it will be warm, and the patient will have a pulse. Whereas if it's arterial, since it's in the arterial system, and that's when we're checking pulses, that's the arterial system, then distal to that clot, there will not be a pulse, or the pulse will be markedly diminished. The extremity or the area distal to the clot will be pale and cold because there's no perfusion. So the blood flow to the tissue distally is diminished. And then you can have the 3 I's, ischemia, injury, and infarct, right? Remember those 3 I's from before? So if a patient has intermittent claudication, what does the claudication mean? Because I know you read that in your readings.
Pain in the leg or in the calf?
Right, it is pain in the leg and the calf, and it could be intermittent, doesn't have to be constant. It could be at rest. Even though the vessels are narrow, the blood flow is adequate to meet the tissues, to meet the demands of those tissues. With exercise or with walking, then the muscles work harder, so that means they're going to demand more oxygen. And if that demand is greater than what's available or what's being supplied, then they're going to end up with the claudication. So the location of the pain kind of gives you an idea or a clue whether it's arterial or whether it's venous, okay? So other things that can bring on a DVT would be, what could you potentially see there as your signs and symptoms? Besides the warm leg, swollen leg, there's other things we can be looking at. Isn't there, okay, immobility, okay, post-surgery. What about the rubor? Can they have dependent rubor? And what does that mean? That's R-U-B-O-R.
Dark red.
It basically is a dependent red, so the foot turns red. Would that be venous or arterial?
Venous.
That would be venous, because arterial, distally, I just told you it was going to turn pale. So just, that's how you know the difference kind of between the two. As you work through your PowerPoints, it's kind of giving you, how the skin would look. They can have some numbness, tingling. Pale would be arterial, or you can have the dark, which would be more, the dark red, which would be more venous. Thin, shiny skin, lack of hair on the skin, etc. Thickened toenails. And they can end up with gangrene because of the lack of oxygen to the tissue, and end up having to have their foot and or leg amputated. So if they have severe peripheral vascular disease, then the legs, it's actually going to shrink and look discolored. That leg will be discolored.
Gangrene is caused by both of them, arterial and venous?
No, gangrene is caused by arterial because there's no flow and they develop the 3 I's.
Okay.
Who can tell me what the ankle brachial index is? The ankle brachial index. And what does that measure? A-B-I. A as in apple, B as in boy, A as in injury. So what is the ankle brachial index?
It's a difference in blood pressure between the ankle and brachial.
Ankle and the arm. Okay. So how do we know that it is positive for peripheral vascular disease? What does the number have to be? Greater than or less than, Orfanelli? Less than. So the number has to be less than 0.9 So between 0.4 and 0.9, it lets you know that they have peripheral vascular disease, but it's more of the claudication. Between 0 and 0.4, it's tissue loss. So the closer you get to 0, the more you're looking at more tissue loss. Between 0.2 and 0.4, we're looking at they have pain at rest. So like that restless leg syndrome. So instead of just with exercise and activity, now they're experiencing the pain just sitting down. So how does homocysteine play a role? What is homocysteine? That's HOMOCYSTEINE.
Blood test for heart failure?
Is it for heart failure? Is it related to coronary artery disease and peripheral vascular disease?
Coronary artery?
Okay. So homocysteine is an amino acid that's produced with catabolism of proteins. So let's just kind of start with that part. Increased levels is related to dietary deficiencies like all your B vitamins. If you have high homocysteine levels, what does that mean?
Is it links to heart disease or?
Okay. So it's related to a higher risk of coronary artery disease, peripheral vascular disease, and stroke. So they kind of use it to test for an early onset of clot formation for heart attacks, strokes, peripheral vascular disease related to atherosclerosis. So just for clarification, when we're talking about venous insufficiency, so this is inadequate venous return over a period of time, that's going to be related to deep vein thrombosis and varicose veins. So the lower extremity will be swollen, it'll be warm, pain will increase if they stand, skin will be thin and shiny, their foot will have a kind of a brown pigmentation, so that rubor. Can we use SCDs on these patients, yes or no? So we're talking about the compression
No.
stockings for a venous clot.
No.
Can we use what? I'm sorry.
Can we put on compression stockings or TED hose for patients with venous clots?
Yes.
So I have a no and a yes.
Yes, ma'am.
No, because wouldn't it make it travel?
Where is it? What do you mean dislodge the clot?
Yes, dislodge it.
Okay, do they not put on sequential compression stockings for patients with peripheral vascular disease in the hospital? If it was arterial, I would agree with you. No for arterial. But if I'm not mistaken, I believe Lippincott does say that they can use the compression stockings or TED hose or SCDs to help. That they may not use the pressure part that's squeezing off the actual device, but they may put on the stockings to promote flow.
So are you saying for DVT or PVD?
I'm saying if you have it's what's written in, from what I understand in Lippincott, if you have venous insufficiency, they can, if you have venous insufficiency, you can use your sequential pressure measurements or your compression stockings or TED hose or whatever you want to call it.
If they have a history of DVTs, can you still use it?
Why do clots form? Because blood becomes what?
Stagnant.
Stagnant. So if they're using the TED hose or the compression socks, that's designed to promote better flow, correct?
Yes.
So then that should eliminate them developing clots.
Okay.
Does that make sense? Because otherwise you're doing nothing to help promote perfusion. What would be your method to promote perfusion? If you don't use a TED hose or compression socks, well, how would you promote perfusion in someone with venous insufficiency?
Mobility.
Okay, so say they are 400 pounds.
Reposition the patient.
Changing the what, babe?
Reposition.
Okay, so when you have to do some kind of range of motion, if you're going to say mobility, because if I'm 400 pounds, I don't think I'm going to be doing a whole lot of position changing without somebody assisting me or someone providing something to my legs to help me.
Yes.
Because there's no way that I would be able to do that, correct?
Correct.
Air mattress, I get that. Exercises from physical therapy. Yep, those are all good ones. But even if I didn't weigh 400 pounds, I still would need to have, something available. So your book does a very good job of comparing and contrasting an arterial versus a venous presentation for insufficiencies and ulcers that can develop. So that's in table 30-1. So it talks about pulses, it talks about pigmentation, it talks about, where you would see the ulcers, what kind of pain they would have, what kind of border it would have, the shape of it, to give you a better understanding of that component. I don't know what page that is, but it's table 30-1. Doppler studies are things that they use to look at the flow. The ankle brachial index is another one that they'll look at for the flow. They're measuring pressures to see what they are. They could have an MRI or an angiography. There's a lot of different diagnostic studies that can be done. So yes, the walking, decreasing smoking, all of those would be good things that can be done. Pain medication. If you're looking at arterial, and this is the answer, I can't remember who was asking that a minute ago. From the arterial perspective, then, you know, they're not going to use those compressive devices. So they're going to elevate the patient's head of the bed, not the legs. Use a chair or recliner chair, or sit with their feet resting on the floor. This is for your arterial person. They'll do some isometric exercises. You know, they're to walk to the point of pain, and once they start experiencing pain, then they're to stop. Then when the pain subsides, then they resume walking. That's for the arterial side. So the pain is kind of a guide on how much they can and cannot do. If they have a leg ulcer, then that's going to actually get, you know, will not necessarily heal with the walking. So they have to be mindful of that. So other things they can do from the arterial side would be vasodilators to help promote flow. Questions about that? Oh, hold on. There's a question on the table. So because if you have a clot in the artery, and you put if you put pressure on that, Melissa, then that can take the clot out. But now that would be more dangerous than in the venous area. So they don't recommend it for your arterial insufficiencies, only for the venous. Any other questions on PVD, peripheral vascular disease? I know we talked about this earlier on in the semester, so it's kind of it's a redo. But all those things are still the same. All right. Oops, sorry about that. All right. Let's see. I have another question related to that, or if you guys have another question related to that. So, venous is swollen and altered pigmentation. Arterial is pale, cool, decreased pulses or no pulses.
No pulse.
No, I'm saying arterial would be no pulses or very diminished, or pulses that you would have to acquire with a Doppler. So that's the machine that kind of looks like a stethoscope, but it's a machine at the bottom of it. And you have to use the KY jelly to put on their foot to try to find the pulse.
Okay.
So can you put a heating pad on a person that has peripheral artery disease? Can you use a heating pad for that?
No.
Okay, no, absolutely not. We do not put that on clients, but they can change positions. They can walk into the point of pain. Do we want them to have on tight clothes or loose clothes?
Loose clothes.
Loose clothes. So those are things that, would be a pertinent to do. Okay.
Okay.
All right. I'm trying to see. Tell me what you know about mitral valve prolapse. Let's slide there for a little bit.
The valves are either not able to close completely.
Okay. Why can they not
And
close? Because they do arch upward into the atrium, and the ejection fraction is low. Okay. Thanks, Melissa and Orfanelli. All right. So when you're looking at mitral valve prolapse, the valves are going to basically bow, and they're going to bow upward, which allows for what to happen once the valves bow upward? Regurgitation. That is correct. So once the valves bow upward, that was Orfanelli, Melissa, both of them, Melissa and Orfanelli. So yes, when the valves bow upward, then that allows for regurgitation to happen. Okay. So what they'll say what's actually happening is that there's a buckling of the leaflets to the left atria, for which they bow up and out. So they basically open out and then open up regurgitation. There's different types of regurgitations. So we're not going to get into all of that. Usually a mitral valve prolapse, does that happen on diastole or systole? Diastole or systole? Systole. So is systole when the heart's contracting or relaxing?
Contracting.
Contracting. All right. So usually when you have this regurgitation, or if the valve prolapses, it's going to be on systole when it's contracting. Overall, the cause is idiopathic. What do we mean by idiopathic? Don't really know the true cause. However, two things it's been primarily linked to. What are they? Okay, genetics. What else? Caffeine and nicotine. So those are the other links. Caffeine and nicotine. 10% is symptomatic and 90% is asymptomatic. So when you're auscultating heart tones, what would you hear?
And you're clicking?
You would hear a clicking sound. And that usually happens mid to late systole. So in the middle of the contraction or towards the end of the contraction. There is a murmur, and that's kind of like turbulent or harsh blowing sound, which is basically turbulent blood flow, another way of calling it or another way of looking at it. So those are things that you're going to hear. So that harsh sound is caused by the disruption of the blood flow into the heart between the heart chambers, or because from the heart into the pulmonary or the aortic system. I can't even get that out. But the blood backflows into the left atria, pulmonary veins, and or the pulmonary system, so hence the lungs. But it could also be due to lupus. It could also be due to a connective tissue disorder that affects the arteries known as Marfan's syndrome. That's MARFAN''S. Usually that person will complain of chest pain, palpitations, dyspnea, syncope, or fatigue with activity. So they have activity intolerance, and then they'll have that mid-systolic click that you'll hear. The treatment for that is going to be a valvuloplasty or a valvotomy or an annuloplasty. There's different types of surgeries that can be done. They need to have good oral hygiene, so that way they decrease the risk of them developing endocarditis. What about dental procedures? If they're going to have any dental procedures done, should they be on any type of pre-medication? And if so, what?
Antibiotics?
Yes, antibiotics for at least 6 months for any dental procedures, or prophylactic antibiotics before any invasive procedures. So when you have this regurg, it does put you at risk for an infective endocarditis, arrhythmias like ventricular tachycardia or PVCs, and then mitral regurgitation.
Can you repeat that?
When you have a mitral valve prolapse, it puts you at risk for infective. Basically, you get an infection, endocarditis. Where would you expect that to be? And the endocardium of the heart, that's the inner layer. Arrhythmias or dysrhythmias, either one. So like ventricular tachycardia or PVCs. And then it can progress to mitral valve. Those patients shouldn't lift anything greater than or equal to 10 pounds. So outside of surgery, we're going to keep them hydrated, have them exercise regularly, and definitely avoid any type of caffeine. The biggest complication is related to a mitral valve prolapse, because we have things backing up, is going to be what? What's going to be our biggest complication? So if we can't push all the blood back, push all the blood forward, and some of it's staying back, then what's going to happen?
Embolism.
We're going to have clotting issues. So they're at risk for thromboembolus. So therefore, what medication do you think they'll be on?
Anticoagulant.
Anticoagulant therapy. Is that going to be short or long term?
Long term.
Long term, especially once they have a prosthetic valve placed. So other medications besides the anticoagulants going to be beta blockers to try to control the palpitations and the chest pain. Usually they are not going to give them nitroglycerin because it doesn't work. Remember, nitroglycerin works on vessels. So it dilates it causes vasodilation. Do we need vasodilation for this mitral valve prolapse? No. Eating habits, they're going to have healthier eating habits, avoid any stimulants. So besides caffeine, you know, nicotine, diet pills, so anything with ephedra in it, they can't take. If they start to experience, you know, shortness of breath, anxiety, fatigue, palpitations, and they need to contact their physician. So any questions regarding mitral valve prolapse? Or anything else you feel that needs to be re-clarified?
So you would give them beta blockers?
Yes, for the palpitations and the chest pain, yeah. But you just wouldn't give them, when people hear chest pain, they think nitroglycerin. But that not for this particular situation, because nitroglycerin works by dilating the vessels. This is not what we're trying to do right now. We're trying to minimize other causes. This is not a vasodilation issue.
Okay.
Does that make sense?
Yes.
Okay. So giving them the nitro will not help their situation. So their chest pain may not be there, but not their palpitations may stay. Does that's what they're basically saying. It's not used to treat that.
Okay, that makes sense.
So I'm trying to see what else about, oh, I know what I want to talk about that. Hold on a second. So when you do have, I mean, you can end up with regurgitation, you can end up with stenosis. Those are all different things that can happen. But I wanted to ask you, where would you auscultate for a mitral valve prolapse? Where would you auscultate?
Be a mid-clavicular.
Fourth or fifth intercostal space.
In the apical part of the heart.
There's a specific location that you would auscultate to hear your clicks, your murmurs, whatever. I shouldn't say it like that, but you guys know what I mean. I wrote that down somewhere now. I can't even find where I wrote it. I'll find it here in a second. But I'm gonna move on until I find it. I had that down as a question. What are the 4 valves? Let's start with that. You have 4 valves in the heart. What are they? Oh, hold on. I'll find that in just a second, Melissa. What are the 4 valves? So you have mitral, bicuspid, pulmonic, aortic, or is that in the right order? What's the right order of the valves from right atria to left ventricle? Not saying that you have that, you do have them. I want to know the order now. And there's a reason why. Is bicuspid Isn't that the mitral? Yeah. It's call it TPMA, toilet paper my assets. So it's tricuspid, pulmonic, mitral, and aortic. And then the way you auscultate for those is APTM. So I call it ape to man. So that's how you auscultate the sounds. When you're trying to find the tricuspid valve, then you're going to place it where the aorta would be, or in that area.
ABTM.
So they are in the order of TPMA, so toilet paper my assets, and then APTM, ape to man. That's how you auscultate.
Okay.
All right. Oh, I did. Sorry about that. Thank you, Melissa. Yeah, it is toilet paper my assets, and then the way you auscultate is APTM, so ape to man. And then I did say, let's see if there's any other questions I can ask you about mitral valve. Yep, ape to man. Yep. All right. So do they have extra heart sounds with mitral valve prolapse? Yes or no? Yes, correct, Orfanelli. They do.
Didn't you say they had the clicking?
Yep, they have the clicking. They also have the murmur. So when you're auscultating, you should expect to hear an extra sound. That would be the mitral click that you're hearing. All right. I think I'm good on mitral valve prolapse and all of that. Did that. Just going through my little notes here real quick. All right, so let's talk a little bit about lab values from the coronary artery disease perspective. Let's talk about those. What's your normal cholesterol? Is 300 normal?
No.
Okay, so less than or equal to 200, right?
Right.
You have a question, Orfanelli? What's your question?
Yes, do we need to know about the mitral stenosis and aortic stenosis?
No, I was checking that just to make sure that, we don't go way too far or too deep. But on your perfusion hand for your concept, the exemplars are heart failure, hypertension, gestational hypertension, mitral valve prolapse only.
Okay.
coronary artery disease and peripheral vascular disease. So that's the reason why I did not go into that. I said I'm stopping here and I'm moving on.
Okay. Thank you.
Yep. And the same, just for clarification on elimination, you have neurogenic bladder, diverticulitis, Crohn's. Those are your three. Bowel obstruction. So those are your only four there. So makes sense. All right, so let's get back to the paralytic ileus, diverticulitis, Crohn's, and neurogenic bladder, spastic and flaccid. So tell me what the normal cholesterol level is. What's normal? Well, so less than or equal to 200 is correct. All right, so how about your HDLs? Are those the good ones or the bad ones? Those are the good ones. All right, so what should that be? What would be normal? Okay, so it should be over 50. What about the lousies? Was that the LDLs, the low density lipoprotein? Less than 100. All right, what about triglycerides? What should that be? $150 or less, right? Okay. So just go back to make sure you understand those. So if you're seeing lab values, you know how to respond appropriately. How do you know if a person has coronary artery disease? Because, you know, your lab values like your HDLs, your LDLs, all of that kind of tells you about atherosclerosis. So would that be considered coronary artery disease? Yes. So we're using those values to determine if they do have coronary artery disease. All right, so if you are trying to see, what did I ask in class? There was something, I'm trying to remember what I asked in class. Give me a second. Okay, if your patient has angina, there's stable and unstable. Okay, Teresa has a great question. Do all lab values need to be abnormal to be considered coronary artery disease, or just one? Really, if your cholesterol is elevated, then they're going to say you have coronary artery disease. Okay, so what's the difference between stable and unstable angina?
One you can control.
Okay, in what way?
With nitro.
Okay, so with nitro. All right, so you have one, stable pain goes away with rest. Stable is with activity and goes away. Unstable is constant. True. So we'll start with stable angina. stable angina usually happens with activity, some type of exertion. You could be running, you could be shoveling snow, you could be raking leaves. There's some type of activity. You could be gardening. And then you'll have a sudden onset of substernal heavy pressure chest pain, right? And then you can have one or more of the associated symptoms that I wrote on the board, whether it's shortness of breath, dizziness, diaphoresis, radiation to the neck, jaw, back, or arm, or tooth. You can have that happen. Upon stopping the activity, the chest pain subsides and subsequently goes away. If it doesn't go away, but at least subsides with rest, and if you take nitro, then it goes away, correct? How do you know nitro is effective? How do you know that it's working? What should the patient report back to you? For you to know that the nitro is good, besides the lower pain, how do you know this is some good nitro? Kind of like the, good drug. How do you know this is a good drug? Decreased BP, those are side effects. The decrease in BP is a side effect. But to know whether or not the nitroglycerin is good, it's not out of date, or it hasn't lost its potency, the patient should report that it's tingling, a tingling sensation underneath the tongue, because remember, it goes underneath the tongue, so it should be like a burning or a tingling sensation. So Melissa, you brought up a couple of side effects. The blood pressure is going to go down. That's because nitro causes vasodilation. So when you dilate the vessels, then your volume is a little bit lower, your blood pressure drops. With besides the decrease in blood pressure, what's the other side effect of nitroglycerin? Side effect. Besides,
Headache.
okay.
Headache.
Headache. So that is one of the key side effects to nitroglycerin. So we will expect their angina to decrease, or that's at least what we're hoping. They're going to have a drop in blood pressure, so we have to kind of watch, where the blood pressure is going, and that's why we take a blood pressure and do a pain scale before we give them another bump of nitroglycerin, because we want to make sure that we're not bottoming out their blood pressure. Okay, but the side effect that a patient will report is going to be a headache, and that's because of the vasodilation effects of the medication. Right? So, when you're giving your patients that, you want them to understand that this may cause you to have a headache, etc. Other questions you want to ask before you give that is what would actually cause their blood pressure to just drop all the way out to the bottom? If they're taking BP meds, okay, we need to ask that too. What else? This is the one around the erectile dysfunction. So Cialis, Viagra, Levitra, any of those. Viagra, yes, we want to ask about those drugs because that also causes vasodilation. So if you give them two vasodilators together, then that's going to cause a synergistic effect, meaning their pressure is going to drop way down. So we're literally going to bottom out their pressure. So we do want to ask about that. And we want to know if they've used it in the last 24 hours. Okay, so we don't
Viagra and what? I'm sorry.
I'm sorry.
Viagra and what? Which medications again, please?
I don't understand your question. I'm sorry.
Yeah, which medications that can have synergic effect with
Viagra,
but yeah.
any erectile dysfunction med. So Viagra, Cialis, and Levitra. Those are the three erectile dysfunction meds. If there's others that are coming out on the market, it would still be the same thing.
Okay, thank you.
Mm-hmm. All right, so we talked about stable. Besides nitroglycerin, what else are we going to give them? I'll answer that in just a second, Melissa. So what else we want to give them besides nitroglycerin? We're still on stable. No, we're not going to give those. Aspirin, correct, Teresa. So 81 to 325 milligrams. They need to chew it and swallow the aspirin, absolutely. So we have nitro, aspirin. We need to give them some oxygen. How much? 2 to 4 liters. Okay, I can accept that. And you may end up giving them morphine for pain if that nitro's not working. So we'll get to that here in a minute. So that's pretty much, as far as management wise. And then we would prep for cath lab. We would prep for, if they decide they want to give a thrombolytic to lyse the clot, those are things that we would prep for. Okay. If we're now moving into the other direction, which would be unstable. So unstable, they would have had the chest pain for 20 to 30 minutes without relief. So stable happens with activity. Unstable starts at rest. It's been going on 20 to 30 minutes without relief, even with the patient taking nitroglycerin if they already had it. Okay. So they can have nausea, vomiting. The chest pain is still described as the same, but the other associated symptoms will be nausea, vomiting, dizziness, shortness of breath, diaphoresis, and radiation. Those are things we're going to still ask about. So despite nitro, the patient has not had relief, and the time zone of that happening has been greater than 20 to 30 minutes. Now we're looking at a heart attack. And then there's different types, which we're not going to talk about that this semester. You'll cover that in 4th semester. Okay, so same thing. We've already did nitro. We can't do rest because it happened at rest. We're going to put them on some oxygen. We'll more than likely give them morphine. We would prep for, either nitroglycerin drip, cath lab, and or thrombolytic therapy. Even if they have stable angina, the doctor may opt to go to the cath lab to see how much blockage the patient has. So that may happen. Make sense? So if the doctor gives them, what's the most common cholesterol lowering medication?
Statins.
Correct, statins. Plavix is a anti, I think it's an antiplatelet, if I'm not mistaken. But that's more for the clot than for the chest pain. It is an antiplatelet. So statin would be the medication to help lower cholesterol. That's the most common. With that being said, if I'm taking a statin medication to lower my cholesterol, what else can I do to lower my cholesterol?
Change diet, exercise.
Diet, exercise. Okay. Those would be some key things to do. Should I ever double down on a dose?
No.
No, don't ever double down on a dose. So if what's the goal of the statins? To lower your LDLs or raise your HDLs?
Lower LDL.
Okay. So this is the reason why we continue the exercise program. We don't stop it because we want to we don't want to, we want to change our diet because the goal is to decrease LDLs and increase HDLs. That's what we're trying to do. So we're trying to reduce our low density lipoproteins, but we're also trying to increase our high density lipoproteins. That way that will diminish or decrease the cardio or coronary artery disease or heart disease risk. Okay. Other manifestations of or other characteristics of coronary artery disease, or what are some risk factors besides diet?
Diabetes, obesity,
Okay,
smoking,
diabetes, obesity, smoking.
increasing alcohol consumption.
Okay, so high blood pressure, diabetes, obesity, smoking, all of those are risk factors that's listed in your book. So just, some are modifiable and some are not. What do I mean by modifiable?
Can be changed.
Some you can change and some you just cannot. Okay.
Yes.
So you accept the stuff you can do and accept the stuff you can't change. So unfortunately, if you're a guy and your granddaddy had had a heart attack and your daddy had a heart attack, you probably gonna have a heart attack. Does that make sense?
Yes, ma'am.
All right. Okay. So any other questions on coronary artery disease? You think you're good on that one?
I got a quick question. Every time there's a heart-related question, like a select all the apply, one of them is smoking cessation education, but the question never mentions that the person's a smoker. Is that always a good choice to pick?
I think it depends on the context of the question, the context of it. If they're asking you something like, what are some risk factors, then that would be a risk factor. Whether they smoke or not, they're just asking risk factors, and risk factors aren't going to change. Does that make sense? If your question has, that your patient does smoke, then that would be appropriate to include. So I don't know I think it depends on the context of the question that's being asked. So if it's just asking you, bare bones, what's the characteristics or risk factors related to obesity? Most people say decrease activity, increase, high carb content. Do you see what I'm saying?
Yes.
Okay. So you would just list the risk factors as they stand. Now, if they're saying that, here you have a middle-aged person who hasn't been to the physician in 10 years, has a high stressful job, blah, 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 eats at 7-Eleven and Dunkin' Donuts. Okay, now you would pick the thing that's related to her as being the risk factors. Does that clear that up?
Yes, thank you.
Okay. So I think it depends on the context of the question. If it's asking you something global or something specific to this particular scenario. But that's a good question. Okay. I think I'm good. I think we're good here for coronary artery disease. What about high blood pressure? Tell me some things about high blood pressure.
It's a silent killer.
Who is it the silent killer for, though? It is a silent killer, but the population that's bringing up this, or this is most impacting, are women. Okay, so women are losing out here, and African American women more specifically, but women in general. They're the vulnerable hidden population that don't get talked about in medicine, which is unfortunate, but that's a different day. So that's a different soapbox for a different day. But if you're developing a teaching plan, the number one thing to do, the biggest point to emphasize with high blood pressure is going to be what? Can cause organ damage. Sodium, correct, Orfanelli. We're going to restrict sodium. That's the whole purpose of the DASH diet. That's why I'm bringing that up. So we're going to decrease salt intake. It doesn't mean that smoking doesn't count, or as far as your teaching plan, but the most important thing is diet, because we know that sodium retains what? Water. So we want to try and minimize that component right off the bat. So I think this goes back to your question, if it has smoking there, and that's why it depends on the context of the question, because there you can, you don't want to always choose smoking, because in this particular instance, salt intake is going to be the biggest thing. So just kind of read the question to see what is it really asking me. So we have some, what else can we do? What can high blood pressure cause? What are some conditions that high blood pressure can cause? Renal failure, heart failure, stroke. Those are all viable. So it can fry out your kidneys, it can cause your heart to become super weak from heart failure. You can end up with a stroke, clots, because vessels are small. So those are high risks right there within itself. So high blood pressure should be taken very seriously, not just, well, these folks are going to get it. No, not necessarily. There's no need to just get it. So let's talk about a little bit high blood pressure in your pregnant person. So is this the person who already had high blood pressure and it was just complicated by the pregnancy, or did the pregnancy induce the high blood pressure? So it starts after 20 weeks. So this is going to be related to the pregnancy. So the pregnancy caused it. What are some signs and symptoms of pregnancy-induced hypertension? What are some things you want to caution your patient about?
Facial and hand swelling wouldn't be normal.
Okay, so edema, seizures, it can affect the fetus, headache, confusion. How does it impact the fetus? What complications can it have on the fetus? Because now, we have smaller vessels, we're impeding blood flow. So premature labor, okay. Placenta detachment, okay. So we can have some placental insufficiency. The growth can be affected, right? Prematurity. So So those are things that would be applicable to the baby. Maternally, for the mother, they'll have the seizures, the hemorrhage, renal and liver dysfunction. So, you know, they can develop coagulation disorders. So, you know, that's all important. But from the fetus, we're looking at the growth being affected. We're looking at prematurity. We're looking at the placenta having insufficiency. That would be on the fetus side. Maternal side, we're looking at seizures. We're looking at coagulation, renal disorders, hepatic disorders. So it's a completely different outlook. What's the other condition outside of pregnancy or that's related to high blood pressure and pregnancy that can happen?
Preeclampsia?
Preeclampsia and eclampsia, absolutely. So if you have a patient that is a pregnant mom and they have, you know, eclampsia, what are some things you want to look for? Or how do you want to what is the assessment of that person first? Let's start with that. How would they present?
Edema.
Okay. Edema is one. Yep. What else?
Headache.
Headache. Okay. Protein in the urine. Yep. Epigastric pain. They can. Yeah. What else? So they're going to have some swelling, some central nervous system changes. So blurred vision, headache, double vision. They could be seeing spots, but that swelling is going to be, you know, pretty general throughout, right? Blood pressure will be definitely elevated. So if it's severe preeclampsia, what are we going to give them? How can we fix their issue? Mag. Okay. So we're going to give them some magnesium sulfate. And when we're giving them that magnesium sulfate, what are some things we want to be looking for? How do you know your patient's having a problem, you know, with the mag?
Reflexes absence.
So reflexes are low. Okay. So now we are giving the mag. Would their magnesium be high or low if we're giving mag?
High.
Okay, so their magnesium started low. That's correct, Melissa. But once we start giving them the mag, then we're expecting the magnesium levels to increase, right? Correct? Yes. Okay, so the thing we have to be looking for is that we don't overcorrect. So if we overcorrect the magnesium, meaning now we have hypermagnesemia, how do we know that we have now given them too much mag? What would we see?
Decreased tendon reflexes.
So everything would be low. Blood pressure, heart rate, respiratory rate. So the blood pressure would be going down, but deep tendon reflexes would be absent. So all of those things that we talked about last lecture with hypermagnesemia. So anytime you guys are giving any kind of medication, you know, like on the last section in fluid and electrolytes, we talked about the low sodium, and then some of the things that, you know, what would be priority if you're giving them the 3% sodium chloride, you know, what would that look like? Those are the things you have to be looking for. Because now if you give it too fast, that's going to be a problem. But you won't know that if you're not looking for those cues. Okay. So just make sure that we assess for the opposite happen. So if their magnesium was low, which is probably why we don't want them to get to the seizure part, but if their magnesium was low, then we're going to try to raise the magnesium, but we need to make sure we don't raise it too high. So we would be looking for the decrease or absent deep tendon reflexes, the low blood pressure, not the low heart rate, the low respiratory rate, the blood pressure getting lower. So those are our signs, our cues, our early subtle signs to let us know, hey, hold on, freeze, we got a problem. Okay. So those, just don't forget about monitoring for those components. Also, what would be a critical lab value related to preeclampsia? So we already talked about protein spilling over into the urine, but is that like critical? What would be a critical lab value related to that?
Potassium.
Not potassium. This is related to the eclampsia stuff. So, we're going to get a chemistry. We're going to get a CBC. We're going to look at their urinary output. We're going to check their deep tendon reflexes, right? Platelets, correct, Teresa. So we're going to be looking at the platelet counts, because that would be low platelet counts would be a critical issue. That's letting us know that we're having in-organ damage or in-organ function. So don't forget to go back to your RISI book on that. What's the antidote for MAG if we've given too much? Now I know everybody know this one. Calcium gluconate, absolutely. Absolutely. Okay. All right. Any questions on the hypertension? What is when you give your patients blood pressure medication in clinical, what do you tell your patients to do, or what do you tell your patient is a potential side effect? Let me start with that. A potential side effect of that antihypertensive. Dizziness, absolutely. So we are warning our patients about dizziness, so getting up out of the bed too quickly, real brisk position changes. So we want them to move kind of slower, but more importantly, to call us if they start to feel dizzy, or if they really want to get up and move around, because we don't want them standing up and then hit the ground. Now we have a fall, and that's going to be, that's not going to look good on those core measures. So we want to make sure that we are addressing that component with our patients as far as patient teaching. So these are things we're already doing in clinical. And before you give that medication, you're going to check and make sure that it's A-OK to give that blood pressure medication anyway. So we're just not going to give it blindly just because, it's on the MAR, or at least I hope you're not giving it blindly because it's on the MAR. So, but also be aware that if we're given like an ACE inhibitor, that can cause hyperkalemia. So, going back to those potassium imbalances that we talked about earlier. All right, so let's, are we good on all of the coronary stuff, the blood pressure stuff? How do you take a blood pressure on a patient? What position, what's the anatomical position they should be in to get a good BP? Sitting up, legs uncrossed. No, sitting up, not lying down. Hand, heart level. They do a lot of that in the dental office, orphanelli, but for nursing students and for nurses, not just students, for nurses, we should have them sitting in a chair and their feet should be flat on the floor, the legs not crossed. So that's their true anatomic position. Don't forget about your basic ECGs. It's very basic, knowing how to count from your R to R intervals. That's, multiply by 10. It has to be a complete conducted beat in order for that number to be valid.
Can you repeat the last part?
If you're getting your calculating your patient's rate, there are 3 ways to do it. However, it's basic ECG. There's more specific ways or more accurate ways. We're basically just trying to get a ballpark. So you look at your R to R wave, and then you multiply that number by 10. But the whole beat, so the P, the QRS, and the T all must be present in order to count that beat. So if you only have like the P wave and part of the QRS, then you can't count it. Because how do you count half of a beat? That's going to be a little difficult to do. Okay. So just kind of follow through on that. Now, if you wanted to look, oh, I'm sorry, go ahead.
What are the specific ECG abnormalities we should know?
The specific ones?
That we should know, like atrial fibrillation, ventricular.
Well, atrial fibrillation we only talk about because we see it in heart failure a lot. But you should know your lethal rhythms, which is your VTAC non-perfusing, your ventricular fibrillation, and your asystole. So you should know those. Those are your lethal rhythms. Now you should know your basic ones, which will be normal sinus rhythm. Now all sinus rhythms are not normal. If your numbers are not within normal range, or if you have an ectopic beat, it's not normal sinus rhythm anymore. It would just be sinus rhythm, and then you would name the abnormality that exists. So if it's a PAC, PJC, PVC, or whatever it is. But we're not going to give you anything that complicated. It'll be just very straightforward. You should know sinus rhythm, sinus tach, VTAC, VFib, asystole. And you should know how to treat it.
Yeah.
So if you have somebody that's in, pulseless ventricular tachycardia, that's what you see on the monitor, and you're the nurse, what's the first thing you should do? Check the patient. So you always assess the patient first. Oh, let me make sure this is true. Second thing you do, after you check the patient, what's the next thing you do? Because you're right there. What do you do? Call a code, then start CPR. Exactly. When you call the code, they're going to be calling respiratory, if whoever the cardiac team is. But until they get there, you need to start the CPR and make sure that the brain's being perfused, not standing in the hallway waiting for somebody to come off the elevator, flagging them down the hall to your room. That's what the charge nurse for and the nursing secretary. So your job is to start get the ball rolling, and then once they get there, then you step aside and you take notes and this, that, and the fifth, because you're going to have to document that in your chart work as well. Does that make sense? So don't be those nurses waiting for the code team to arrive. Well, no, we didn't start CPR. We're waiting on the code team. That's not how you do that. So you assess and then you intervene, and then you intervene appropriately. So that's what, you know, those little blue cards that you got from American Heart Association, that's what you're capable of doing, as well as the AED. So, or if they have a defibrillator. But outside of that, you know, it's still assess the patient, call a code, start CPR. And hopefully while you're doing that, somebody is bringing in the defibrillator. I can't see how they wouldn't once that code blue is called. So if you're, you know, your respective facility has a code team, at least get the crash cart near the room or in the room. So that way, you know, oh, the team's here, but we have no crash cart to work with. So yeah, now we got to wait for somebody to go get that. That's going to kill up time. Okay. The other thing of, you know, blood pressure management, our goal is outside of decreasing the blood pressure, but why are we really decreasing the blood pressure? What's our focus there? What are we really trying to prevent?
Stroke.
End organ damage. Good, Teresa. We're trying to prevent end organ damage. So those things could be stroke, it could be heart failure, could be a heart attack. But at the end of the day, we're trying to prevent end organ damage in our patients. So that's kind of that's how we know that our blood pressure management is effective. How do you know that Lasix is effective? So if your patient has heart failure and you give them a diuretic, how do you know that it's effective? Nah, not that one. So if I have a heart failure patient, remember, left-sided heart failure folks are drowning. Right-sided heart failure patients are swelling. I want to listen to
edema.
I want to look for lung sounds. So if I'm giving it to my left-sided heart failure patient, I want to make sure that this fluid is moving out of their lungs. Does that make sense? So if I'm looking at, you know, reducing my volume in the body, you know, excessive volume, then what would I look at then? If I'm looking at reducing excess volume,
The weight.
then I'm going to look at, you know, the decrease in swollen feet. I would be looking at, you know, the weight and things of that nature. Okay. Or urinary output. You know, how much urinary output, that's giving me an idea that I'm decreasing volume based on that output. So if I give somebody 10 of Lasix and they don't put out a whole lot, then that's going to be a problem. Right? Sorry about that. Yep. Okay, so any other questions about all the peripheral vascular perfusions, blah, blah, blah? You know about cardiac output, so we talked about that in class yesterday. Any questions on the elimination that you may have?
The neurologic bladder, please.
What about the neurogenic bladder? What's your question?
The exact causes.
I'm sorry?
The exact causes of the neurologic bladder.
Oh,
The causes.
there's a whole bunch. It's all central nervous system related. So stroke, multiple sclerosis. I mean, that's right there in your literature. So all that's there. So any spinal cord injury, spinal cord lesions, herpes zoster, a herniated disc, pelvic surgery, all of those things can cause a person to have a neurogenic bladder because there's a disruption between the brain and the bladder. Brain tumor, Parkinson's, those are other neurovascular conditions that can affect that besides a stroke.
Which book, please? Because I didn't find the resource for this.
It's in your
specific
textbook. Did anyone else not find it? So for, just make sure I'm not stuck, I'm not losing my mind because that's a high probability. Yeah, when you go to the concepts and you click on neurogenic bladder and you select ebook, then it gives you the management for that. There's a couple of areas. Neurogenic bladder disorder 663 and 665. It's not a lot of pages.
Okay, thank you.
So yeah, they have a whole chart there, table 27 too. So it gives you kind of your, where there will be the main issues. So with all that being said, that kind of gives you an idea of, it tells you even how to manage it. So the goals would be to prevent the bladder from being over distended. We're going to prevent the urinary tract infections and then kidney damage. That's the goal. Depending on the person, it's individualized. It can be temporary or permanent. There was a question that came up. So it depends on the situation. Because you may just have some swelling, it goes away, your neurogenic bladder issue is fixed. So we want to make sure that, we're giving them a bladder, doing bladder training, like Kegel exercises. So we want to get PT or OT in there for that. Medications that can also be used to treat neurogenic bladder. Making sure they drink so they can help train the bladder. The patient may have to use intermittent catheterization. So it's almost like doing potty training for a kiddo. So, a kiddo's going to, when they get up in the morning, the first thing they need to do is pee. All right. So a couple of hours later, 2 to 3 hours later, then you're should be running them to the bathroom. By then they probably drank about a half a liter of some liquid somewhere. Okay. So here with when you're trying to retrain the patient, you want to have them drink with every meal 400 to 500 milliliters, at least 2 liters a day. If they have an indwelling catheter, then they need to drink at least 3 to 4 liters a day. It's a little bit of a sterile technique, Teresa, but they're going to, and it should be, because this is going to go into the urethra. So you just don't, want to you want to keep it clean as much as possible. So even as nurses, we still put on sterile gloves and all of that. So I'm not going to downplay straight cats or the intermittent catheterization, because we're taking a tube and we're sticking it into a sterile area. So yeah, we need to make sure that stays that way. Correct. So you're going to clean it the same way. The question is, or the question was, is it the same as a regular insertion for the intermittent catheter? And yes, it is. The tube is a little bit smaller, but it is still the same procedure. So you need to clean the area with the betadine. You need to have a clean hand and a dirty hand. The only difference is you're going to take that catheter out at the end after you drain out the bladder. Okay? So we're training the bladder, so we're not going to just, dump it out completely. We're going to take out about a half a liter. Have them stay away from caffeinated drinks because they make them pee more. Carbonated drinks make them pee more. And it also irritates, voiding, and it gives them the increased frequency or the increased urge to urinate. So if we decrease the fluids, then the patient won't have enough or produce enough urine. So, those are all things we covered in class, but don't forget about your medications like your oxybutynin or your ditropan. So those things. We're not going to give them any citrus fruits or anything like that. And we talked about that as well, but things of what not to give. I think that was pretty much the biggest thing of, and why do we do the self-catheterization? What's the purpose of that? What does it do? What is its goal?
To empty the bladder?
It is to empty the bladder, but we're also reducing UTIs. We're giving the patient a lot more independence with the self-cath, because if they're not self-cathing, then that means they're wearing like some kind of diaper or a Depends or something like that, right? We're decreasing distension, but we're also promoting their self-esteem, because no one wants to go around town thinking they're GTG, good to go, and then they pee on themselves. That's not going to be good. So that self-catheterization does kind of promote that, because now they know I at least have 2 to 3 hours before I need to do this again, so they can kind of time their events, or time their catheterizations. And I had a friend who had a lot of bladder problems, and she was self-cathing everywhere. We'd be at a restaurant. She was like, all right, I gotta go to the bathroom and self-cath. I'm like, okay, good Lord. But, she didn't care. She was like, hey, it's something I have to do. She wasn't willing to go all the way home and then come all the way back. It wasn't, for her, it wasn't that serious. But hey, do what you feel you got to do. But, it depends on the kind. Maybe a little bit too bulky. And, if you don't want people to know your business, then that will be, kind of crazy. But you got to be consistent with emptying the bladder. That's the whole portion of bladder training, being consistent. Training that bladder, hey, we need to empty out. So we just can't, one time do 2 hours, then 4 hours, then, 1 hour. You got to be consistent with it and then build from there. Okay. What's the best diagnostic tool for diverticulitis? For diverticulitis, what would it be? I'm switching now. I'm leaving the urinary, going to the GI. What is the best one? CT scan, correct. CT scan is the best diagnostic tool for diverticulitis. If your patient is having an acute phase of diverticulitis, which 2 things would be contraindicated? Which 2 diagnostic studies would be contraindicated? Barium enema and a colonoscopy. Why? What's the rationale? What will happen there? it will cause a perforation. That is correct. So that's the reason why we don't do those two studies in an acute phase. So what would be concerning from an abdominal assessment standpoint that you would consider to be a priority when you assessed your patient's abdomen? What should your abdomen normally be upon assessment? Soft, yep, normal bowel sounds, correct. So if the belly was hard, would that not be concerning? Hard and distended? Yes. So we don't want, we don't want folks in there with hard bellies. And now, when I say a hard belly, I'm not talking about someone who's, got a six-pack and they're super chiseled. I'm talking about a person that's big, it looks like a mound, and it's hard as a rock. That's what I'm talking about when I'm saying, a hard abdomen. That would not be appropriate. That would be an emergency, a medical emergency at that particular point. Are we going to feed these clients, or are they going to be NPO? They should be NPO. So we're not going to give them anything until after their situation has subsided. Okay. So we're going to graduate them, for lack of a better word, from one dietary measurement to the next. All right, so let's look at some a paralytic ileus. Are we going to feed those folks, or bowel obstructions? So bowel obstructions are mechanical or non-mechanical. So are we going to feed them? No, they're going to be NPO as well. And what else are we going to do for them? So they're NPO. And what do we need? We're going to NG tube them, not necessarily suction, but we're going to put in an NG tube. So mechanical and non-mechanical are your two types of bowel obstructions that you will have, or you will treat. So yeah, you got to be careful about that component. Another concern with bowel obstructions, there's different types that your book outlines, but a paralytic ileus basically means there's been peristalsis of, not peristalsis, there's been a decrease or a cessation of peristalsis. So nothing is moving forward, nothing. And there's different types you can have, especially in kiddos, where you can have loops of bowel. You can have bowel telescoping into the other. But at the end of the day, those bowel obstructions can take folks out the game. And you can have an obstruction where the person has diarrhea or constipation, depending on the situation. So there's not just one type of presentation for bowel obstruction. So go back to your RISI book to look at that, if you haven't looked at it, since we just covered it yesterday.
Miss Hudson. So the book says that for patients who are not going to get any surgery, that we have to maintain GT suction for up to 3 days, and we have to assess the output.
Yeah.
See how if it's improving or not.
You're doing my point was, what do you have to put in, which is an NG tube.
Yes.
You're going to now decompress the belly. So when it says by suction, it'll either be to intermittent wall suction. So every so often it'll turn on.
Okay.
And empty out the belly.
Okay.
So the physician may start with continuous, but then go to intermittent wall suctioning. But yes, you're going to monitor INOs. You're going to definitely see the output. And all bowel obstructions do not require surgery. So some will, some won't. So you're right about that.
Okay, thank you.
You're welcome. Good question. All right, and so what else about bowel obstructions? Will they have bowel sounds? It depends. It really depends on if it's a partial or complete obstruction. So some will, some won't. It will be hypo. You are correct. All right. Any other questions about bowel obstructions? Okay. All right. I think the only other thing was Crohn's. Any questions about Crohn's? The only other thing I'll say about a bowel obstruction, if they don't treat it, what's going to happen? If it's not treated, before sepsis, what's going to happen? What's the sepsis is going to, peritonitis and perforation, yes. So sepsis is correct, Teresa, but before they get to the septic part, it's going to perf into the bowel, into the abdominal cavity. And then we're going to have peritonitis, and then we'll end up with sepsis. So that part is true. All right. Any questions about Crohn's? What's the most common electrolyte imbalance with Crohn's? Since they have a lot of diarrhea, skip lesions, cobblestone, it's usually related to inflammatory diseases, potassium imbalance. Would that be hyper or hypo? Hypo, that's correct. That is all correct. So anything else you could think of? What about, can they get anemia? Can Crohn's people have anemia? Yes or no? Yes, they can, correct, Orfanelli. So yes, anemia is definitely going to be something that we want to monitor. This is why we're doing that CBC. And so at this point, usually the anemia is going to be iron deficiency. So we're going to be looking at all, how to manage that better with calories and proteins and B vitamins, folic acid and all that. So they got to have sufficient calories and protein. Any other questions you guys have? Impaired absorption, correct. You have a question, Teresa? Oh, all right. Well, if you guys are good, then I'm good. And we will catch up. We'll see you. Enjoy your holiday, and we'll see you Monday. Best to you. Study well. We'll see you then.
I have a question, please, Ms. Hudson. Do we have to know the ulcerative colitis?
No, ulcerative colitis is not on this test. So Crohn's, diverticulitis, neurogenic bladder, and bowel obstruction, more specifically paralytic ileus. That's it.
Okay, thank you so much.
You're welcome. Got that, Jennifer. I will look for it and send it out. I appreciate you reminding me. Thanks, Jennifer. All right, guys, happy Thanksgiving. You're welcome. Bye.
You too. Thank you. Bye.